Now starting. All attendees are in listen-only mode.
Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, Operational Dashboards. This webinar is being recorded and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. I would like to thank HRSA for allowing us to make this webinar possible. As a reminder, please complete the post survey at the end of the webinar. Your responses are very important for us and help us improve our training and technical assistance activities. I'd like to get started, and the National Center for Health and Public Housing is a project of North American Management, and we are supported by the Health Resources and Services Administration, HRSA. Our mission is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. And I am very honored to introduce our speaker, David Wagner. David has been a management consultant to physicians since 1985. He is skilled at all aspects of running medical practices, specifically FQHCs and RHCs. He has run practices of all sizes, from single practitioner practices to multi-specialty, multi-service line FQHC systems. He is skilled in optometry, pharmacy, primary care, dentistry, and behavioral health, along with the specialties generally seen in FQHCs and RHCs. He is knowledgeable on 340B operations, whether they be in-house or contracted to outside pharmacies. David earned his master's in healthcare management, summa cum laude, from the University of New Orleans. He completed his undergraduate in international business and finance at Loyola University, New Orleans. David handles strategic planning, board training and review, CEO training and review, as well as general strategic programs for the group's clients. He also acts as CFO in the shared CFO system and handles all aspects of HRSA financial and operational reporting, including UDS. So thank you, David, and I am turning the presentation over to you. Good afternoon.
Good afternoon, everyone, and good morning to those on the West Coast. Thanks again for having me talk this through. Operational dashboards are something that are near and dear to my heart, because when I started using them kind of intuitively ages ago when I first started practicing, because a lot of my physicians couldn't really tell much by the financial statements I was showing them and the various different reports that I would bring to them on a monthly basis. So I came up with this primarily as a tool to help me explain to my provider clients how we were doing strategically, how we were doing against our stated goals and objectives. And when I went through my master's program is when I really honed this skill, as well as when I worked at a major system in the New Orleans area that used the operational dashboards kind of throughout its organization to help communicate not only the goals and objectives that each individual person has as part of that major system, but how they were doing and how the whole system was doing. So it's at that entity that I really saw the wide range of dashboards, and am happy enough to be able to bring them now to the FQHC environment as I'm working with my clients. As I'm out on site visits with HRSA, it's also a very interesting and sought after concept when dealing with the boards of directors and the key management staff. So hoping people that have their site visits coming up might try to put some of these things into place, because it really helps the boards of directors as well with their strategic management of the operation. So without further ado, what is a dashboard? So a dashboard is basically a document. Normally they're single pages showing a snapshot of systems or perhaps the whole organization, it rolls up to a single page or two. But basically, it's the snapshot of the current status and sometimes historical trends of the success at attaining the goals of the organization. Their dashboards provide a at-a-glance view of key performance indicators, known as KPIs, relevant to particular objectives. And the term dashboard actually came from the automobile industry. You know, when you look at your instrument cluster, you basically see how fast you're going, the oil you've got left, the fuel you've got left, things of that nature. And if you can envision, you see it in an instant, and you just look at that one place, and you know everything going on with that automobile. That's really what we're talking about when we're speaking about a dashboard. Effective dashboards actually answer a few problems. As I mentioned, the first, key business metrics are abstract and sometimes difficult for employees and boards and executive teams to digest. You know, you're looking at a financial statement, a profit and loss statement. Well, you know, even if it's got a variance analysis, that kind of gives you an idea. But if you bring it to a dashboard approach, which I'm going to show you a couple of examples in a second here, it standardizes the visualizations across time so that anyone can understand the concept of red, green, or yellow, perhaps arrows showing the magnitude or a stoplight. You know, those types of things are real easy for people to read, and then they can dig deeper into the reports if they need to understand why what's happening is happening. Employees feel lost or need guidance. This is the transformational, the behavior transformation that a dashboard can give you, because it distills all of the goals and gives you a platform to communicate these things in very easy terms. For example, front desk, we need to see 100 patients today to break even. Well, the dashboard might show them they have 180 appointments today, but they have a no-show rate of 50%, so they're still going to be a little bit below. So again, a very easy way to give people information in an actionable format. And then trends, across systems, all of our systems are very complex now. We have multiple computer systems, multiple reports. Sometimes these reports shift over time if you change to a different computer package. Well, a dashboarding system actually brings everything together into one place, and that one document can become your historic data repository to be able to look back over time at those metrics. And we're going to go into some best practices there. So let me just show you a couple of examples of a dashboard that I've used over time. There are a myriad of examples of these things, and if people have you know, after we're finished with the seminar, if you've got some questions about different types, or if you just like some more, you can email the center and I can get some more examples out to you. But what we start with, I have two different ones that I use in the systems that I run. Basically, there's a weekly dashboard that mine are 2 pages. You've got the dashboard page, which is this. If you see the red, yellow, and green, real easy to see. Look here, we have 225 appointments booked. We only needed 190 for this week. We're 35 ahead of schedule. But look at this, my no-show rate's 12%. So it's kind of a place for me, as anybody in the system can look at this and be able to tell, even with that no-show rate, I think we're probably going to be close to being okay. But look at 1 week out, we're already a little bit behind the 8 ball here, and then 3 weeks out, we're really far behind. So again, not to tell you what these mean for this specific dashboard and system, because they're going to be different across different systems, but just illustrating how easy this is to see. And then you go to the details sheet, and you can kind of see the operations metrics of the providers. And again, these are specific to a particular system because it established these things as its goal. Another example is in monthly operating review. This is the one that I really got at the major health system that I was with in New Orleans. Again, another wonderful thing to look at, rather than seeing a financial statement that shows me what I did this month, what we budgeted, what we did last year, and then the variance analyses. Again, it's just red, green, and yellow. Real easy for me to look at, and then dive in deeper into the reports later. So let's move into some definitions and acronyms. As we all know in the health center world, we have a zillion of them. I'm not going to go through the HRSA, Health Resources and Services Administration acronyms, but again, if someone needs those, I'd be happy to send those out. But basically specific to today's discussion, there are three major types of dashboards: operational, strategic, and analytical. We talked about key performance indicators. KPIs is the acronym that we use, and this is what HRSA uses. Performance measurement, we've got baseline, we've got goal. Quality improvement, quality assurance, QI/QA. Everybody has one of these. So let's dive into the specific definition of the types of dashboards, because I'm pretty much going to be talking about these two. You've got an operational dashboard, which is that weekly example that I showed you, because this one is more of, it's actually numbers, it is actually data. It's less of key performance indicators, this little no-show rate, more of actually just data that you're looking at here. These are normally used, again, by everyone in the system, but first and foremost, these drill down to the provider level, to the service line level, production, things of that nature. Strategic executive dashboards, those are more key performance indicators. They can also have numbers, but a big part of these is actually showing in a just a glance view how many of these are actually you know, what you're accomplishing and things of that nature. And then analytical, these are our run charts. If any of you guys have a moderately complex lab, you're going to be using run charts to analyze the different analytes in your laboratory system. Most don't, so the other thing this is, you see this a lot, is your quality assurance process, your QI/QA. As you're monitoring every month the movement of those different HRSA measures, you're actually seeing the analytical. So let me pause here, and we're going to, I'd like to test how many people are using dashboards currently. And again, this is any type of dashboard. Pretty much everybody uses the quality dashboards, but just interested to see how many of you already use some sort of a current dashboard.
So right now, with a 77% response rate from all of the attendees, 69% are saying yes and 31% are saying no.
Excellent. That's great that you guys are using these. And we can talk again if we have some time at the end of the conference if you have questions about the dashboards and things. So let me jump into key performance indicators now. So a key performance indicator, a KPI, is a metric used to evaluate factors crucial to the success of an organization. So they differ by organization. Most of us actually have the KPIs established by HRSA, aka the clinical and financial measures that we review. Other centers also have a lot more having to do with the new patient percentages, things like that. So KPIs should also link to the unit, to the productivity for individuals, and you use them to define roles, responsibilities, and establish accountability. So that's the KPIs here also should be the ones that you have in your strategic plan. So even though we put in our strategic plans mostly what we have in our grant documents, the SAC or the NAPs, the strategic area competition, service area competitions, or the new access points, what you want to try to do is take what you said you were going to do and develop these KPIs. And I've got some examples of a few of them that you would be able to use. So performance measurement is generally defined as the regular measurement of outcomes and results which generate reliable data on the programs, and this is basically setting baselines, setting the goals, the baselines being what you saw or what you experienced at the beginning of the analysis period. If you remember on your measures as you submit them to HRSA, those are the beginning ratios that you calculate and then move forward towards your goals towards the end of your analysis period. And then last but not least, quality improvement, quality assurance. All of us have this type of a plan. We all submit to this when we get our grant funding, but some of us do it in a little bit different ways. And what I'm going to propose to you is that using these dashboards throughout your cycle can actually help you summarize very well for your board as the measures move across time and as you do your improvement activities. So let me break here. The other question I had was, since so many of you guys actually use dashboards, I'd really love to understand the type of dashboard you guys might be using, operational, strategic, or analytical. So I'd like to take a few minutes to ask that question, and you can select all that apply. And again, operational are that weekly dashboard example, the ones that might show no-shows, appointments, things that are more critical to see on a weekly basis. Then the strategic is the monthly operating review. Maybe some financials, of course bringing in some production and collections and some other key performance indicators. And last but not least, the analytical, that's more what you would probably be using in your laboratory or with your quality improvement cycle.
So about 50% have voted. So let's say 20 more seconds and then we'll close the poll.
Okay.
All right, and then here are the results.
Okay, so it's pretty balanced with a lot of people already using operational dashboards. Excellent. So again, why do we use dashboards? We want to summarize the measurements, spark quality improvement, and then document quality assurance measures. They're great for board members. I've seen a lot of discussion during the site visits around having dashboards for the general board instead of financial statements, which are more useful for the finance committees, and then the run charts and things like that are better for the actual quality assurance committees on the boards. But for the general board, a dashboard, really simple and operational, or even a KPI type dashboard is excellent. Useful for executive leadership. It's really good for executive leadership to be able to look at their operation in one shot and kind of get an idea of where they might need to go to make improvements. And then for staff motivation, this is truly when a dashboarding system has matured, you can actually use it to motivate and to actually change behaviors. So operational dashboards, how do you put them together? How do you make them successful? This is really the focus of today's talk. So the first important thing is to evaluate the organizational priorities, and that's akin to looking at your strategic plan and using it to develop these priorities. We want to define the audience, we want to define the transparency, and how are we going to distribute these? There are a lot of options I'm going to talk about in a few seconds. And then from the actual first 2 points, you're going to establish the KPIs that you're going to highlight on the dashboard. And dashboards change over time, but the best practice, just like any statistics or any kinds of reporting, it's better to, once you set it, you try not to take away from or change those KPIs or how you're getting those KPIs as time progresses. It's okay to add things as long as you don't get too busy. And I have to admit, my dashboards are kind of getting to the point of being too busy, which is when you would break them off into 2 different ones. But let's but again, just to establish them and then determine the reports to use for data. This is a critical thing that I'm going to spend a little bit of time on. And I have to tell you one that nobody really taught me or prepared me for. I learned this through the School of Hard Knocks, so I can definitely give you some experience there. And then build your sample and run a test. You start with the dashboard that you think is going to be the one you want, and then you run it as far as making sure the data is correct and the presentation of that data matches what you expected. And then not only that, but actually giving it to people and let them look at it and kind of feel for it and give you some responses. And then of course the end all, which is modifying behaviors. When we're accountable to one another through a transparent type system such as this, it actually becomes an internal or intrinsic motivator for most people. So evaluating the organizational priorities, the dashboard is only as good as the actions it generates. And that's a very important statement to make. So again, we want to know why we're going to put the dashboard together. Most importantly, making sure that whatever we are looking at is going to maximize either the health, the well-being, the financial well-being, the access. Everything is from the perspective of our patients, because that's why we're here. But other things you want to look at is meeting your stated objectives in your service area competition, your SAC, or your new access point, your NAP, driving quality improvement, driving sustainability, increasing grant leverage. This is a major thing now. If you haven't been through a site visit this year, this is one of the major things that we look at, because HRSA always intended for the grants that we're all receiving to be used as kind of a starting point, but then you leverage your income from all the other sources of program income. And then last but not least, the needs of your community being served. Very, very, very important. So there was a study done by Quality of Healthcare in America, the Institute of Medicine. They wanted to spell out what is important from the patient perspective. Critical areas that all health practices can improve in. So take a minute to read those. Do some of these resonate with you? Most of these things are exactly what we have agreed to provide to the patients of the health center program, again, through our SACs and NAPs. So we want to make sure that our KPIs and our dashboards definitely take this into perspective from the perspective of the patients as we're looking at and establishing our objectives. The second important part, defining the audience, the transparency, the distribution channels, the who, what, where, when, how, and why. So the audience is who is viewing it and why. What do they have at stake? What do they hope? What do they need to accomplish in behavior modification? One example is the board. They're reviewing it. Why are they reviewing it? Because they're supposed to strategically run the operation. They're tasked by HRSA. They agree with HRSA to do that. So That's who and why. A provider is viewing it. Why? Because we're going to have a report out to let them know where they are in perspective or in relation to their goals and objectives to sustain the system with the number of patients that they see. Patient satisfaction, maybe their new patient percentage, maybe their panel size. Transparency, where and when will people see this dashboard then? Will everyone be able to view it, or is it hidden? My strongest recommendation on dashboarding is to ensure that everyone sees it. Of course, that means you don't put sensitive data on it, like a particular person's pay, or things on there such as Mrs. Jones did something wrong. You never tell people in public that they did something wrong. If something is wrong, it's publicly stated that the system itself didn't operate as it was supposed to, but absolutely applaud them when they're successful in public. So if Mrs. Jones was key in hitting the appointment setting metric because she called in 10 patients that were on a wait list when we had 10 no-shows, you definitely applaud her in public on this report. Distribution, how will they receive the dashboard? Lots of different options here, and I'm assuming this is where we're going to have some questions. I basically have subscribed to just using Excel and either emailing it or posting it to the company intranet, just because it's an easily printable system. A lot of people put this on their bulletin boards around the different practices. So this is what I've been using, but more recently I've actually been involved with a few health centers that wanted me to program their old Excel documents into a web-based live portal, and there are quite a few of those different portals around. Some people will use the dashboarding that's internal to their EHRs, their electronic health records, or their practice management systems. Other great options, those I just like to make sure that we know how the information has been relayed and that you can actually make edits to those, but definitely other ways to do that. So we talked a little bit about key performance indicators. So these are the indicators that generally show up on dashboards in areas. Production, number of patients, number of no-shows, number of visits, things of that nature. Access times. Patient access is the time to the next third available appointment, things of that nature. Quality, experience of care. This is the quality metrics that we're all really familiar with, as well as patient satisfaction scores. System support. What I mean by this is a sustainability question where, for example, if we have providers, primary care physicians, nurse practitioners, and we actually have an in-house pharmacy, how often are we able to have our patients use our in-house pharmacy to support that system? Things such as how often do we have a primary care patient that actually uses our dental clinic, that actually uses our behavioral health clinic? And again, there may not be wrong or right answers to these other than what you've used in your budgets to establish your productivity for that fiscal year or that time period. Operations, things such as the phone answering times. A lot of systems now are able to get reports out of their telephone systems that can actually show things such as how quick are those phones being answered, how many are dropping, how long is it taking you for each phone call. Those kinds of things are important to help support operations and make sure that you have a smooth operation. Things such can be employee related, such as, okay, we know there's going to be employee turnover. We hope not, but we know that we're probably going to need to lose one person a month due to turnover, whether they quit or let go, retire, things of that nature. So you can monitor those things as well. And of course, the ever-important finance. Other than quality, that's the other biggest piece that the boards look at. And you know, and it's really much better to have KPIs, things such as the timely filing of claims, the days in accounts receivable, the days cash on hand, the the variance to net income, the variance to charges, the variance to net collectible, things of that nature. And again, if people need some additional help and talk about these, I'd be more than welcome via email to give you some more examples. But don't ignore getting your the people involved that actually be reading and using these dashboards. You have to make sure that you keep this under control, but what you're going to find is as soon as you start asking people these questions, you're going to come up with so many KPIs and so much information that it's going to help you write the dashboards, and it's going to help you decide how many and how to deliver them and things of that nature. So I'd love to take a quick break here and ask, KPIs are you already monitoring? Even if it's not using a dashboard, but what are you watching? What are you looking at the board level, at the executive level? Can we ask that poll? I have to tell you, quality has dropped here because it's a given, since we all have our HRSA measures that we have to measure. So I'm assuming everybody measures quality and watches those KPIs.
Okay, we're at about 60% response, so take another 15 seconds, then we're going to close the poll.
And just production are things like the number of patients per day, patient origin, new patients. Patient access is more your metrics of how quickly patients can get into your system for care. Quality, again, I dropped because assuming everyone's doing that because of the QI/QA process. System support, how many pharmacy fills, referrals between service lines, things of that nature. How many new patients because of staff recruiting the patients. Operations, phone stats, employee satisfaction, provider record completion times, how many open orders a physician may have, things of that nature. And last but not least, finance, the break-even, the grant cost per patient, the total cost per patient, the medical cost per medical visit, some of those other financial metrics.
And here are our results.
Okay, very interesting. Production, again, is normally one of those that's highly monitored, as well as finance. And again, people that are in various systems that have pharmacy and optometry and other systems, system support's one of those magic ones that can help really spark sustainability. Okay, thank you for your responses. So let's go into now what makes a good metric, aka a KPI. They must be understandable. Should be understood by everyone who has access to it. So this is an important consideration when you're building these dashboards. Remember how we talked about who is the audience? Got to make sure that we're addressing this when we're building these. Comparative. The comparative is better because they should either show variance analysis over time against industry benchmarks, the goals that we actually have set in our strategic plan. Some method of comparing is important, and it's better to keep the same comparative concept on a dashboard. And again, we can talk some more about that. Rate or ratio, that makes a good metric. I mean, absolute numbers are sometimes required, like we had our production numbers per provider. But when you can actually put a rate or ratio in there, which is showing the percentage that provider, based on the production that they produced last week, is helping the system meet its goal, is much more meaningful than just showing the doctor had this many visits or the nurse practitioner had this many visits. And then behavior changing. Can someone take meaningful action based on that metric? Again, as I continue to implement these dashboards and practices, they at least give you a 10 to 20% increase in productivity almost immediately due to the nature, the transparency of these. So when you can actually tie these metrics directly to someone's either pay or just basically their public announcement of how they're doing on their goals, it can be behavior changing. It creates an intrinsic accountability like nothing you've ever been able to see before. So next I was telling you about the report. So this is what I learned from the School of Hard Knocks. Dashboards are a great concept, and the huge company that I worked for had all of this built already, but didn't really have a good way of explaining it to new people coming in. So I kind of learned through the School of Hard Knocks before this that I needed to be careful of this and use as many as you can as reports from the same reporting system. So let me give you an example. So without naming the name of the software package, I used to use a software package at one of the FQHCs where I was the COO, and don't think any of you guys are listening, but if you are, you know exactly the one I'm talking about. It was a fantastic system, but when it had its canned reports inside of the actual practice management system. It also had canned reports inside of the EHR, mostly for meaningful use and for reviewing of the clinical measures and things of that nature. But it also had this other analytics package that when those canned reports couldn't give what you wanted, you could actually program something in the analytics package. And I learned the hard way, and some of you guys are probably giggling because you go through this every single day, that when you run the same conceptual report from all three systems, you're going to get slightly different answers. And that is just a major issue because of the database origins, the last point on this slide for various reports. Some, and you got to understand your reports, even if they're canned, but some of them take encounter data to report. For example, when you actually see the patient, sometimes it'll capture that from the encounter data instead of capturing that from the appointment system. You just got to understand that, because what you're going to want to understand is where these reports are coming from, and to the degree you can, you want to make sure you use the same database origins for clusters of your KPIs in your system. So you wouldn't want to use encounter data to show how many appointments were kept that day, as well as using how many appointments were made that day, because that might come from the appointment data and the encounter data and potentially the claims data. So as an example, if the encounter data is used but your system will only show that appointment was kept after the charges are dropped, and then unfortunately one of your providers is 10 days late filing his or her encounters and closing them, so your actual results can change over time, because as they file more and more of those encounters, all of a sudden that appointment kept is rising. Whereas if you did all of your appointment capture from the appointment data, most systems, when an appointment is kept, you can click on, patient arrived, and that way you would get a good static picture of the appointments made, appointments kept, no-shows, things of that nature. And I hope I'm not either boring or confusing you, but we'll find out as we get closer to the end if you have questions on that. But just these are the things that I found over time making mistakes as I was analyzing my reports. They weren't validating properly across different reports. Just use these as measures to try to help you as you're building these. Again, my most important one is these UDS measures. As possible, use UDS reports directly out of your system, the same ones you're going to use to annual UDS report to do your report outs on a monthly basis. Just because that way your data again at the end of the year is not going to shift on you because of some sort of a system error instead of you using the UDS reports, if that makes sense. And then last but not least, minimize the number of reports, because these can sometimes take a while. I'm going to show you basically on mine how this is, and again, this is the way I designed this because I was having to juggle 10 to 15 of these a month, you know, with my various 10 to 15 clients that I had. So what I would do is basically have two things. I would have, this is like my data input sheet, and I'm going to expand this a little bit. I hope everybody can see this entire screen. But what I would do, you know, this is an example of one that was across several different sites, several different service lines, as well as several different types of providers. So what I would do is just know I would go in here and key. So you know, I would make this grayed out. So these are all, this syncs up with the appointment system that I actually would pull the reports from. So this whole piece might be one or two reports. So it's just, you know, key punch, key punch, key punch. And again, design this data entry spreadsheet specifically to follow exactly how your report comes out of your system. It's very rare that you can automate this easily. It can be done, but it's very rare that you can automate this because, for example, you know, this provider, if they had no activity this week, they may not even show up on the report. So, you know, when you're trying to export this stuff into an XML or a CVS or any kind of file to be able to upload straight into this Excel document, it doesn't work. So again, easiest way is to just set up your dashboard entry screens to exactly mirror how it's going to spit out of your system. And then, so this is my monthly total for that entire month. So I pulled this report on a monthly basis. You also have this same kind of report on your weekly template. It's just that I hid it on here. It's just that you would pull it for a weekly basis, but it's the same exact appointment report that I'm pulling. So, and again, this is, I think I clicked the wrong button, sorry. I was trying to open Publisher. All right, so that's that. And then look over here, pharmacy. So this particular system had a pharmacy. So what we would do is I also wanted to system support. I wanted to understand how many scripts that provider was writing to my own internal pharmacy. For meaningful use, I wanted to see the total number of scripts that they were sending electronically so that I could calculate some measures of for that as well. Here's my access time. Again, another report would give me my time to next third available appointment. I had it set to do same day, which is critical. I had it set to do established patients, new patients. In this third available appointment for those who have not seen it yet, the IHI, the Institute for Healthcare Improvement, I'm not sure that they coined this concept, but they definitely teach this concept of looking at the third available appointment because that really gives you a good idea of what patient access is. And again, depending on what you want to do, same day I always want that at 0 because I don't ever want a patient to be turned away and can't be seen. Panel sizes, people that are patient-centered medical homes, or again, some people, you know, you see this in the IHI, depending on the different provider types as a panel size. So these are just some different ways that you would actually key this data in to the system. So going back, then what you're going to see is this sample dashboard that I put together. You're going to go in and actually key all this data in. Here's all the data. You're going to look at the way it's calculating this on the actual dashboard itself. So for example, this is part of the run test. You get, after you set up the whole thing and after you or your designee, whoever's building this, actually keys all this data in, they've already programmed all the places where it's going to appear and calculate and things of that nature. You're going to want two different people to key from those same exact reports to not only measure whether or not there are easy places for key punch error, but also they may actually go through this and find places where the calculations aren't exactly as they should be. So that's why you're going to actually program the whole thing and then do this run test to be able to make sure that all the information is populating correctly. Then you're going to actually distribute it using the planned channels. So this is another key measure. At an ACO that I was with recently, we had set up this wonderful dashboarding system and a way to get this out to the providers that were in the accountable care organization using the intranet for them to be able to log in and see their reports. Well, very quickly, of course, I was the compliance officer there, so one of my measures that I had in my internal KPI for my internal job duties was how many doctors are actually accessing the intranet on a regular basis, aka monthly basis, to ensure that they're actually keeping up to date on the reports. Well, I found quickly that hardly any were getting in there. So make sure you're going to put it through the channels that are actually going to be used to distribute it, and then get feedback from the staff. Very important. Get their feedback on how useful is this dashboard to them. And then last but not least, modify behaviors with the dashboard. Tie system sustainability to the matrix. Each person and what they do on a daily basis is sustaining the system. Each metric should be tied to a specific area of the strategic plan. I've seen some health centers that I've visited recently, as I start going through this piece of the process, they've actually written a guidebook for their board to understand their dashboarding. That was a fantastic system. They actually showed each staff person in their annual review, they showed on the dashboard itself what metrics were being used to assess them using the statistical part of the annual review and what everything meant. Tie service lines, same way you're going to tie your system sustainability. One of the systems had really fun pizza parties when different pieces of the system hit their objectives. And they tied all of this not only to the line or the operational area, but they helped their staff understand where all of this activity rolled back up into the master strategic plan. And then last but not least, individual performance. So everybody thinks about provider performance. Some people actually tie specific productivity using a productivity formula with that provider's bonus structure that year. A lot of places don't do bonuses quite yet, but more and more and more are moving to that. So at the very least, however, just look at this transparency. Even just having everybody in the system seeing and kind of we're all competitive, self-competing against one another, whether they're competing against another person or if they're just competing against their own budgeted RVUs. People are going to look at this and their behavior is going to adjust. But even specifically, if you're going to put some sort of a performance indicator in people's annual reviews, or if you're going to put some sort of an actual benefit, a financial benefit tied to their bonuses, things, make sure you write a guide to the dashboard and distribute that to everyone, and then specifically show them where their financial or just other reward mechanisms are going to trigger depending on what they're actually going to do. And then lastly, I learned this at the system. We actually, as managers of service lines, actually ran a huge multi-specialty division for one of the hospital networks. And again, this is where I learned and really honed the skill. They would have me prepare this dashboard. So even the process of me preparing my departmental dashboard for that campus helped me see and really understand what was going on, even more so than if I had just gotten this dashboard already finished and sent it in. So this in itself can actually modify mid to first level management in their positions. So, and then last but not least, reward success in public, collaborate on opportunities. I would use these dashboards, and you can see on the weekly dashboard that there's a little section here that talks about, on page 1, turnover risks, none, recruiting, onboarding, patient complaints. When I actually got a patient satisfaction result that mentioned Mrs. Jones was wonderful, she was so helpful and caring during my appointment, she made me feel like she was taking care of me as my daughter, something like that, I would actually put that entire verbiage on here. Sometimes even attach a little snippet from there was a Press-Ganey review at that point, from the patient satisfaction review. But if I have a complaint, never do I mention the staff person, but you definitely could use that to document things. So again, you're going to have these different resources. There's some things from HRSA. There's a few things that I found just out in some of the other quality improvement sites, and I've actually got some additional, if people would like that, some additional links for other resources and articles. And I'm going to end here. I'd love to be able to take a few questions. If we run out of time, I would offer, Dr. Leon, if people have questions, please have them email you, and I'll be more than happy to continue answering questions. I just feel like this is such an important thing, and it's truly a transformational tool that you can put in place that, as you can hear, I love these. So I'll help anybody that has questions. So any questions now?
Thank you, David.
We have a question. Someone is saying, did you use SQL to create the report you're talking about? The report that you were showing.
So this report you're talking about, it's a simple Excel document. So if you're talking SQL, are you talking about to create the underlying report that I could use to populate all of this information?
Yes.
Yeah, so I never could get that to work, quite frankly, because I didn't have that type of reporting infrastructure available to me at the systems. Now, I have to tell you, at the Accountable Care Organization, we did. So they were able to use SQL to get some clinical measures and things of that out, to where all I had to do was upload them into the Excel document, and it perfectly populated, because all the line items would stay exactly where they were supposed to be. But no, I just used Excel.
Another question is, how long did it take you to establish the baselines for your dashboards?
Okay, so if you're meaning a lot of your baselines are already done because you've got all of your HRSA measures. But what I would do is basically, once you get your key performance indicators, which are basically the ones that use the baseline approach, it doesn't take that long to calculate them, because what we're going to do first is decide what the KPIs are, and then, for example, the total cost per patient. We know the HRSA calculation from the UDS manual. So what we're going to decide is, when does our baseline start, which again normally aligns with the beginning of your SAC or your NAP, just to kind of give people a starting point, and then align everything else along with that same baseline. Does that make sense?
And then another question is, when would you use a dashboard instead of charts and graphs to present quality data?
So I am a strong proponent, as are most of the clinical reviewers that I go out with on the site visits and the governance reviewers. For the general board, it's better to show them just a dashboard approach for quality. Not the quality committee, because they need to see and dig into the data and more of the details. Now, I do have to tell you that when I do a clinical quality dashboard, it at least has variances from goal at the period that we're looking at, but it also has the trend. So you can see, at the beginning of the year we might have been at X, and then we can see at the end of the year we're already at Y. And it's usually a rolling 12-month look back at the quality. But again, I don't do every month for the general board, because then it becomes overwhelming for them. Does that make sense? Did I answer the question?
I feel you did. The next question we have is, when you speak on transparency, do all staff see all dashboards?
And again, that's a decision point. So transparency, all staff that have any sort of result that is tied to their activities should see that dashboard. And if you're following through with my train of thought, every single person in the practice pretty much has a direct influence on some of these statistics. So I'm a huge proponent that a dashboard is meant for every single person to see it. Now, some people do not like the finance dashboards to be released to everybody. So in those instances, however, you can, instead of having a net revenue dollar amount, that dashboard could potentially be a percentage of projected net revenue, if you follow my meaning. But I really think it's critical that everybody sees dashboards. And that's a good point, though, because I'm not proposing that you have one dashboard for the entire system. But what I am proposing is that you have at least one dashboard for the entire system, if you get my little nuance there. So like the ones I showed you for the sample monthly operating review, that would be the board and the key executive team. But if you don't want to have that level of data to every staff person for dollars, that's usually where people have a little bit of uncomfort, is the production dollars. Then you can use those key performance indicators as percentages and things like that. Okay?
A few more questions we have left. One is, have you found that any particular departments are more difficult to find metrics on than others?
That's a good one. I'm just trying to think if I have, because I really don't remember having an issue. You have to look past the HRSA metrics, of course, but I don't think that I've ever found one that doesn't have some sort of metrics that we can apply. But again, if people have definite questions, whoever asked that question, if you want to email me your thoughts or the department you're concerned about, I would love to dive deep, and I can help you find those.
All right, just a couple more questions left. We've got, about how many hours a month would you say are needed to maintain all the reports you presented? This person is trying to estimate the amount of staff needed.
Excellent question, and thank you. I probably should have gone into that as well, because that's part of one of the planning stages. So this system not inclusive of the staff time to actually keep the data and keep it in the system, of course. But just producing the reports probably took 30 minutes, and I believe this one, if I'm remembering right, had 8 different reports. And I'm saying this one, the 2 examples that I showed you. And then it would take me roughly an hour to key it and validate it to make sure I didn't have any key punch errors. So it's pretty quick process, and again, that's why I came to the conclusion of minimizing the number of reports, minimizing the number of systems I need to produce those reports, and to make it an easy process. Because a lot of times I would handle these until I started giving them to my different departments to handle. Okay.
And then the last question, other than people asking for samples of the dashboards, which are you able to provide those?
Yeah, I can definitely get y'all some more. So what I'll do is put together a bunch of them. I've got some that I like from some of these online web-based systems. I've got some that I've been collecting from the different sites that I've been going to as a site visitor. Of course, I need to redact the information off of those, so it might take me a couple of days to get those to you. But sure, I'd be happy to share more of those.
Great. We can put those online, folks, under our archive webinar section on nchph.org, and that's where these slides will also be available by the end of the day tomorrow. And then we'll have the dashboards up as soon as he gets them to us. And then the last question we have is 90% of providers close encounters timely, but 10% are terrible. I am concerned that showing 90% how bad the 10% are may make the 90% worse. We are working on the 10% with limited success. What are your thoughts?
And I understand your fear of that, but it had absolutely the opposite effect, I have to tell you. But you know, I don't know your system, so this is kind of where you have to be a little careful with the politics. But it actually helped one provider, because I've been through that, I know where you are. It helped one provider, how do we say that sensitively, decide or self-manage themselves out of the system. I had another instance where the you know, it kind of held management accountable for terminating that person from the system, because you know, management is ultimately responsible for making sure this gets done. So if everything they're doing is not being effective, then management needs to let that person go. So, you know, it held management accountable. So it's kind of both areas. And again, if you'd like to talk through your specific situation offline, I'm more than happy to just give you my thoughts after we talk. But it's not a bad thing to do.
And that's all the questions we have.
Okay, thank you so much.
All right, thank you, David, and thank you, Brendan. To all attendees, please complete the post survey. This helps the National Center for Health in Public Housing to improve our webinars. And if you have any training or technical assistance need, please contact one of our staff members. You can also visit our website, www.nchph.org, and you will find archived webinars, monographs, fact sheets, training manuals, newsletters, information on our regional and national symposiums, and information on how to submit one-on-one technical assistance. You can also join our mailing list and receive HRSA updates, information on funding opportunities, information on senior programs, resources and services, and information on upcoming webinars. You can also follow us on social media, and you can follow us on Twitter or subscribe to our YouTube channel. This is our contact information. Once again, I'd like to thank David for this wonderful presentation. If you have any questions, you can submit your question via email. My email address is jose.leon@namgt.com, or you can send it to Brendan Quinn. His email address is brendan.quinn@namgt.com. Thank you very much and have a great afternoon.